Dr. Phillip B. Duncan is the Medical Director, Heart Care for You, Cardiac Health Management Network, PC, Affiliate Associate Professor of Medicine, Virginia Commonwealth University, Chester, Virginia.
Good evening, and thank you all for having me. This has just been fantastic. Just catching a little bit of it. You know, it's hard to follow one of our young stars at ABC and Dr. Horn, but he brought some excellent messages. I'm going to try and get us on time, so I'm going to move quickly, so I won't go through all the slides. But my issue is ABC's initiative to improve access to the best quality health care, particularly for minorities, because minorities are in this country, African Americans are a minority that is a high-risk population. So I know we haven't talked about ABC, but ABC is an organization that's been around since 1974 with international membership of over 1,700 individuals. Now, I always tell people that in order to be a part of ABC, you don't have to be a cardiologist and you don't have to be black. So anybody can be a member of the Association of Black Cardiologists. I'm hoping that before everyone leaves here, we've got someone here so everyone becomes a community member of ABC. Our mission is to promote the prevention and treatment of cardiovascular disease, including stroke, in blacks and other minorities, and to achieve health equity for all, to reduce the burden of cardiovascular disease and disparities. And the idea is to at least reduce the disparity in cardiovascular outcomes by 20% by the year 2025. But the idea is to ultimately eliminate disparities. This is an interesting slide. We'll talk about a little bit, but the point here, without not going over all the details, is that for a multitude of reasons, a myriad of reasons, there remains a difference in the outcomes and excess mortality in cardiovascular disease and heart disease in African Americans in this country, despite having some of the best medical care available, but not necessarily having access. So what's been happening is we're seeing this reduction in cardiovascular disease plateauing. So we say we're going to, rather than try and tackle everything at once, because there's so many issues that result in disparities, there's so many issues with access, we're going to try and drill down. And we actually came down to two areas that we want to work on initially. One is the standardization and centralization of what's called the prior authorization process. By a show of hands, how many people know what prior authorization is? Oh, okay, that's good. Maybe a third to a quarter to a third of the folks. Prior authorization is the thing that says that somebody has made a decision in a suit in an executive office that in order to improve their profit margin, they would have someone else who has maybe a high school diploma speak to your doc so that he can get that person's agreement that you can get the therapy that he's decided you get. And that can be a procedure, that can be a therapeutic procedure, that can be a medication. So that's what that process is. And we've looked at the process, and I'll talk about it a little bit. We looked at the process and actually talked to some of these insurance companies because they don't care, and in terms of what it does. They're looking at the bottom line. They're not looking at black and white. They're looking at green. So when we talked to them about it, they said, well, show us some evidence that African Americans are disproportionately denied when they're put through this process. And we said, hold up. Wait, you're asking the wrong question. The real question should be, how many people don't even get the opportunity because you've put up such a barrier that we don't move forward. And so folks, as we see, for example, with peripheral vascular disease, with some of these novel therapies, people don't even try because they know what an imposition is going to be to get the therapy. Excellent example is AHEFT, Bidil. Now, this is a drug that in this group of very sick people, in a disease that has somewhere between a 30 and 50% 5-year mortality when you're diagnosed with that heart failure disease, that we know has a mortality worse than most cancers. So we have this drug that we studied it in African Americans, actually the only study exclusively in African Americans, and we found a 43% reduction in mortality. 43%, very, very, very robust. And so the drug was approved. The first drug approved with the proviso that you have to be a self-described African American to benefit from this. Now, no, the story gets deeper still. It gets deeper still. So then what happens is when we look at this therapy, which is a combination of two drugs that have been around for a long time, but put together in a way that we found is this effective, we found that in spite of that, and this was 10 years ago, actually more than 10 years now that this study was completed and we found that and the drug came to market, 7% of the patients who are candidates for Bidil get it. 7%, Bidil or the combination. So that's not an issue of even the clinical research. That's an issue of access. And in my office, I know that when I try and order this drug, I have to go through this onerous prior authorization process. So that's one of the things we said, okay, we've got to tackle this. We got to put some pressure on this. The other is very simple. There needs to be better communication between pharmacists and physicians. We know that people go to the pharmacist. Pharmacists are a tremendous wealth of information for patients, but we know often, patients are getting one set of information from the pharmacist, another from the physician. Sometimes several doctors are ordering medications, so we need to look at mechanisms to improve the communication. So we said we're going to work on those two areas. So we set a very, very aggressive timeline of 12 to 18 months, where we are, in fact, rolling this out with ABC, where we're doing research and feasibility in the prior auth area, and I won't go through all the details because I see that 5-minute marker up there. And we hope to implement and launch our plans close to the end of 2018. Real quickly, in our prior auth, we said that we would develop a rationale so that we ask the proper questions and do the appropriate studies and print out and publish a white paper so that we can better articulate to the payers why this system needs to be changed and standardized. We also have reached out to a number of the organizations involved with Association of Black Cardiologists, and we're putting together a toolkit so that we can give particularly providers who serve a predominantly African American population a toolkit to give them some tricks of the trade to make it easier to get to that point of ordering the certain tests if they feel it's indicated, or medications. One of the things that we felt is that if you are in a system where you have limited resources, then it doesn't make a difference if you have the same obstacle presented to everybody. If you have less resources, then the obstacle is greater for you. So what the insurance companies or what the payers have told us is that, oh, everything's equal. And we said, yeah, it's equal, but it's not equitable, which is what we're looking for. In our other area, we are behind in this initiative, and we did that by design. So that is the work we're doing on developing greater communication between healthcare providers and pharmacies, and looking at things like e-medicine and other tools and telehealth to help us improve that bidirectional communication. We have a number of sponsors that are working with us on this initiative, but we have taken the lead and let everyone know it's not just about getting these things into people, the idea is that we want to see greater health equity. With that, I think it's time for me to yield the floor. Did I get out before the zero? I see it sitting there. Okay. And we'll start taking questions. Thank you.